Welcome back to Pharmacist Michael's Happy Healthy Living. This is video number 3 in our depression series. In this video, we're going to talk about the treatment of depression with medications. How do we know what medications to start with? How do we know if they're working? What are some things we need to be careful of? As a board-certified psychiatric pharmacist, I have spent years dealing with the treatment of depression, and one thing I have learned is no two patients are the same. What works for Sally may not work for John, and vice versa. During the initial evaluation, we need to obtain a thorough patient history. This includes a medical history, a family history, a psychiatric history, and previous suicide attempts. It is very important that we also obtain a complete list of medications and herbal supplements the patient is currently taking, as some of these may make depressive symptoms worse. We need to check labs, including thyroid and vitamin D levels, complete blood counts, and chemistry. In the psychiatric unit where I worked, we checked vitamin D levels on every admission, and I can tell you, at least where I live, most people are deficient in vitamin D. It is important that we get a complete psychiatric evaluation as well. If the patient has bipolar disorder, our treatment will be completely different. Bipolar patients should not be started on serotonergic drugs for depression, as this can cause a manic episode. Once we complete the initial assessment, if medications are the chosen treatment, we would normally start with an SSRI, SNRI, bupropion, mirtazapine, or vortioxetine. The initial choice depends on several factors, including the doctor's experience with various medications. Yes, it matters what the doctor is used to using. They have their favorites, and antidepressants are no different. The age and sex of the patient. Sexual side effects can be a big deal with antidepressants. Depressive symptoms of the patient. Someone who isn't hungry and can't sleep is a good candidate for mirtazapine. Smokers and those with low energy may benefit from bupropion, and if the patient suffers with pain, Cymbalta is a good choice. Of course, we need to worry about cost, prior response to antidepressants, safety, drug and supplement interactions, as well as other medical conditions the patient might have. The next step is to see how the initial medication choice works. We usually define a positive response as at least a 50% improvement in symptoms. This can be found by using a depression screening tool. It is important to note that all antidepressant medications, except ketamine, take 4 to 8 weeks at an adequate dose to show full effects. Of course, if the patient experiences side effects that are not tolerable, we would stop the medication as soon as that occurs. So here is what normally happens. If the patient has no response to the medication after 4 weeks, we switch to another medication. We do this more quickly in the hospital because we just don't have time to wait that long. If the patient has a partial response, we increase the dose. We could also consider adding a different medication. If the patient has a full response, we keep things as they are. This initial phase is known as the acute phase of treatment. Once we achieve significant clinical improvement in symptoms, we can move to the continuation phase. The continuation phase lasts 4 to 9 months, and during this time, the medication or medications identified in the acute phase should be continued at the same dose and frequency. If we stop medication after the acute phase, the risk of a relapse is 20 to 85%. If depressive symptoms recur during the continuation phase, potential causes should be explored. These may include substance abuse, increased stress, and poor adherence. Remember, medications can't work if they aren't taken properly. The last phase is the maintenance phase. This phase is recommended for those with chronic depression or a history of at least 3 depressive episodes. This phase may last indefinitely. And finally, let's briefly talk about the drug classes used to treat depression. Be sure to look for videos on specific drugs on my channel. Let's start with the SSRIs. These are often the first class of medications tried and work by increasing the amount of serotonin available. Drugs in this class include sertraline, fluoxetine, paroxetine, citalopram, S-citalopram, and fluvoxamine. The big side effects with these are gastrointestinal problems, 8 to 30%, such as nausea, diarrhea, anorexia, or weight gain, and sexual side effects, 6 to 28%. These can be troublesome and include erectile dysfunction, delayed ejaculation, and even anorgasmia. Serotonin syndrome. As with any serotonergic drug, we need to be aware of serotonin syndrome, also known as serotonin toxicity. This can be life-threatening. Symptoms of serotonin syndrome include GI distress, hyperthermia, altered mental status, agitation, hypertension, tremors, increased sweating, and a rapid heartbeat. If you experience these symptoms, see your healthcare provider or go to the emergency room right away. The next class is SNRIs. These drugs increase both serotonin and norepinephrine and include duloxetine, venlafaxine, desvenlafaxine, and levomilnacipran. These drugs can increase blood pressure more than the SSRIs. Duloxetine, or Cymbalta, is good for pain relief, so those with depression and pain can benefit. Tricyclic antidepressants are not used as much for depression anymore. Some drugs in this class include amitriptyline, doxepin, desipramine, imipramine, and amoxapine. These drugs are more dangerous in an overdose than the first-line agents and have worse side effect profiles. We still use these drugs for other indications, such as insomnia. Monoamine oxidase inhibitors are used very rarely. These drugs require a special diet and are really only used as a last resort. Bupropion, or Wellbutrin, increases norepinephrine and dopamine. It has some interesting properties. It is the antidepressant least likely to cause mania in a bipolar patient. It helps reduce cravings and is useful for smoking cessation and in combination with naltrexone for weight loss. It is important to note that bupropion is contraindicated in those with seizure disorders. I have released a video on bupropion and will place a link to it in the description section of this video. Mirtazapine, or Remeron, also has some interesting properties. It has a more complicated mechanism of action. It has some antihistamine effects, which makes it effective for those with insomnia. It also increases hunger, so we often use this drug for depressed patients who aren't eating and have trouble sleeping. This drug does have some sexual side effects, but less than the SSRIs. It can cause dry mouth and can interact with other CNS depressants, including alcohol. This medication should be taken at bedtime due to its sedative effects. I'm going to save ketamine for the next video in this series. I strongly suggest checking this out if you have depression that isn't responding to other antidepressants. Ketamine can be administered via nasal spray or as an IV infusion. Treating depression with medication is a complicated process. I suggest seeking out a psychiatrist or psychiatric nurse practitioner if you have had multiple depressive episodes or any suicide attempts in the past. If you have any questions about this subject, feel free to reach out to me by placing a comment in the comment section of this video, or you may email me at michael@pharmacistmichael.com. Be sure to check out the other videos in the depression series as well. Don't forget to subscribe to this channel for more happy, healthy living information. My name is Pharmacist Michael. Be happy and be healthy.